Hi everyone, I'm Kamar Belghazi and I'm a PhD student at the Department of Gastroenterology and Hepatology of the Academic Medical Center in Amsterdam, the Netherlands. Today I have the honor to discuss our article that was recently published in Gastrointestinal Endoscopy entitled Long-Term Follow-up Results of Stepwise Radical Endoscopic Resection for Barrett's Esophagus with Early Neoplasia. First, I would like to thank all co-authors for their contribution and GIE for this opportunity. The cornerstone of endoscopic treatment for Barrett's esophagus with early neoplasia, which means high-grade dysplasia and early cancer, is endoscopic resection of focal lesions. However, after focal endoscopic resection, the residual Barrett's tissue carries a risk of metachronous lesions in up to 30% of patients within 5 years. Therefore, eradication of all residual Barrett's tissue is advised. Stepwise radical endoscopic resection is a technique where the entire Barrett segment is removed by endoscopic resection during subsequent sessions, providing tissue samples for optimal histopathological diagnosis. Previous studies have shown that stepwise radical endoscopic resection is highly effective in eradicating Barrett's esophagus and its associated dysplasia. Complete eradication of neoplasia is achieved in 83 to 100% of cases, and complete eradication of all intestinal metaplasia in 80 to 92% of patients. Because most studies on stepwise radical endoscopic resection only report on the short-term efficacy and safety outcomes, the aim of our study was to assess the long-term durability of successful stepwise radical endoscopic resection. For this study, we analyzed the follow-up results of 73 patients who were successfully treated with stepwise radical endoscopic resection for Barrett's esophagus with smaller than 5 centimeters with early neoplasia. The median follow-up duration of our study was 76 months. The annual incidence rate of recurrence of neoplasia was 0.2% per patient year of follow-up. So only one patient had a recurrence of submucosal cancer that was found after almost 11 years of follow-up. The patient could be curatively treated with an esophagectomy. This case illustrates that patients with early Barrett's neoplasia are at risk for recurrence of neoplasia, even after eradication of all Barrett's mucosa. Therefore, recurrent Barrett's mucosa in patients with a baseline diagnosis of early neoplasia should be treated additionally, or alternatively kept under frequent endoscopic follow-up when treatment is not an option. We also found that in 16% of the patient, recurrent endoscopically visible Barrett's tissue was diagnosed. This accounts for an annual incidence rate of 2.6% per patient year of follow-up. However, in all cases, the recurrent Barrett's tissue was limited to small Barrett islands or tongues. The excellent long-term results of stepwise radical endoscopic resection described in our paper are promising. However, a major drawback of this technique is the associated high adverse event risk. Previous studies have shown that up to 88% of the patients treated with stepwise radical endoscopic resection develop a stricture. Nowadays, most patients with early Barrett's neoplasia are treated with radiofrequency ablation with prior endoscopic resection of visible lesions if present. This approach has demonstrated comparable rates of eradication of dysplasia intestinal metaplasia, however, without the high stricture rate that is associated with stepwise radical endoscopic resection. Therefore, one may question if there is still place for stepwise radical endoscopic resection in the treatment of Barrett's esophagus with early neoplasia in the current practice. We believe that stepwise radical endoscopic resection should be considered in selected cases. I will now give a few examples. First, in patients with extensive visible abnormalities in a short Barrett segment, stepwise radical endoscopic resection may be a good alternative to focal endoscopic resection followed by RFA because it allows for optimal histopathological evaluation. Furthermore, in the case of extensive visible lesions, widespread endoscopic resection will most likely result in a stenosis, hampering subsequent ablative treatment with a balloon-based or focal RFA device. In these patients, one may consider removing all Barrett's mucosa by endoscopic resection before stricture formation can occur. Second, occasionally patients show a minimal response to RFA treatment. We know based on previous studies that 4 independent predictors are associated with a poor response to RFA. These predictors are active reflux esophagitis, endoscopic resection scar generation with Barrett's epithelium, esophageal narrowing prior to the RFA treatment, and a number of years of neoplasia. In patients who show a poor response to RFA or in patients with a combination of predictors at baseline, stepwise radical endoscopic resection may be preferred over RFA. And finally, there are centers where no RFA treatment is available. In these cases, stepwise radical endoscopic resection might be an alternative treatment approach. In conclusion, stepwise radical endoscopic resection for Barrett's esophagus smaller than 5 cm with early neoplasia results in excellent long-term efficacy with a very low recurrence rate of neoplasia. However, because of the high associated stenosis risk, stepwise radical endoscopic resection is nowadays not the treatment of choice, but it may be considered in the previously mentioned selected cases. I want to thank you for your attention, and I hope you enjoy reading our article.